好，大家好，那欢迎来到下午的场次哈。那这个场次会用英文来进行哈。那我是台大公卫学院的林先和老师。So the session will be conducted in English, and my name is Shenho Lin. I am currently the professor in the Institute of Epidemiology and Preventive Medicine. And the theme of this session is epidemic analysis to inform COVID control efforts, the experience from Taiwan. And we are very pleased to have five excellent speakers from different fields of infectious disease control. And as you might be aware, in the past few months, we experienced a relatively large outbreak in northern Taiwan, and the speakers of today, they contributed to the analysis of the outbreak through different approaches. And so without further delay, I'm going to introduce the speaker for the first talk. And so we're going to change the order of presentation a little bit. So the first speaker will be Professor Zhan Daqian. Professor Zhan is a research fellow from the Research Center for Humanities and Social Sciences of Academia Sinica. And many of you probably have heard about his talk on the application of GIS on infectious diseases. So he will be sharing his experience of applying GIS during the outbreak in New Taipei City. So we welcome Professor Zhan. Professor Zhan, the stage is yours. Thank you. Professor Zhan, you probably have to unmute.
Okay, can you hear me, right?
Yes, now? Very well.
Okay. Good afternoon, everyone. Thanks for Professor Lin to organize these sessions. I slightly changed my topic. I want to share the experience in both Taipei City and the New Taipei City. So in my talks, I will show you a lot of maps in today's talk. So before my presentation, I want to say thank you to some organization and my co-workers. First of all, I want to thank the Department of Health in Taipei City and New Taipei City to provide us the data, and also my students and research assistants, and also Professor Lin and Professor Zhang to co-work on telecommunication data. So this is my outline. So first of all, I will introduce the overview of COVID-19 outbreaks in Taipei City and New Taipei City by spatial and temporal perspective. And the second one, I want to evaluate the policy impacts on flattening the epidemic curve of COVID-19. As you know, in May and June and July, we suffering the COVID-19 outbreak in Taiwan. So I want to evaluate this kind of approach, especially for level 3 alert on human mobility, not only on the quantity but also the structure. The second one is the extensive rapid test screening in community. We also evaluate the impact on controlling the disease. And the third one is related to all my talks, because I will using the maps and the GIS to tell you this story, and also tell you how the first line decision makers using this map to make the decisions. And the last one is I want to highlight the importance of community sentinels on early detection of the cases in the communities. So first of all, I want to share this map to you. So as you can see in the left side is the cumulative instance from the week 18 to week 28, and the right side is the cumulative cases from among these 11 weeks. As you know, the Central Epidemic Command Center announced Level 3 alert on May 15. So we want to, you can see on this map, in Taipei City and in New Taipei City accounted for more than 80% of cases, local confirmed cases in Taiwan. So today we will look more deeply on these major heated areas. In this map, you can see the spatial temporal dynamics of COVID-19 in instance at the district level in both cities. So the temporal windows here, we already defined in the previous slides from early May to the middle July. Okay, so among these 11 weeks, we can see the transmission dynamics in both cities. Okay, so in the middle of the map, you can see the cumulative instance among these 11 weeks. Okay, so you can see the highest districts in the middle one is the Wanhua districts. Okay, so and you can also see the second to the Wanhua. You can see the neighboring districts in purple color had the second highest cumulative instance. Then you can see the third wave and the fourth wave away from the hardest hit districts, Wanhua. And in the ring map, the innermost ring is week 18 and the outermost ring is week 28. So you can find Wanhua had the earlier, stronger signal in week 18, and the neighboring districts had also some sporadic signals. And the weekly instance was high in week 19 in the second ring. So also you can find in that week on May 15, which is the last day of the week 19. Okay, and in week 20, the third ring had a very high instance in that week. Then some districts persisted peaking for 2 to 3 weeks and went down. But also have some weeks having more than 5 weeks peaking stage. So you can see the red colors here, like in Wanhua, in Zhonghe, okay, in Sanchong. So you can see in Taipei City and in New Taipei City, they have some persisting high districts. And then we apply the spatial temporal autocorrecting indicator named spatial temporal GI star for considering the spatial and the temporal dependencies in this case. So in the left panel, you can see this panel without considering any temporal autocorrelation. And at the right side, we're considering a temporal autocorrelation up to 8 weeks. So okay, so you can see the purely spatial or hotspots in the right side, in the left side, there are like 7 hotspots there. And also, if we consider in the temporal dependency, you can see the persistent high districts also those 7 districts that include in Taipei City, the Datong district, Wanhua district, and Zhongzhen districts. And then in New Taipei City, you can find the Sanchong, Banqiao, Zhonghe, and the Yonghe districts. Okay, so by GIS and by spatial temporal autocorrelation methods, you can easily to find those hotspots, and we can find the reasons why they have still high hotspots there. So after that, we want to discuss the 2 approach to slow down epidemic. Although the central government, they provided many policies to control the outbreak. In this talk, I want to discuss 2. The first one is a soft lockdown policy by the Level 3 alert. So we will measure by the mobility reduction and also structural change from the telecommunication data. And the second part, we want to discuss the extensive rapid test screenings in the communities. So as you know, if we can have this rapid test screening in the communities, especially in those hotspot areas, so you can find as early as possible to those susceptible cases and to try to reduce the silent transmissions in the communities. And the second one is we're using the GIS to encourage the people located in the hotspot areas and or those villages where the patients having longer hidden periods in the communities. So first of all, we measure the morbidity reduction by the April community report. So you can see they have two vertical line here. The right side is the level 3 alert in Taipei and the New Taipei City, and the right solid line is the level 3 alert in whole Taiwan. So after the level 3 alert, you can see the case reductions in both New Taipei City and the Taipei City in the upper one. And in the lower one, you can see the morbidity reduction by the transit from the April morbidity. So you can see the after the level 3 alert in Taipei City and New Taipei City, the morbidity is reduction around more than 50% compared to the previous one. And the second one we want to highlight is that we not only measure the quantity, we also want to measure the structure change by the telecommunication data. So in this case, we're using the age, people age older than 60 years old, because those of population accounting nearly 30% of the confirmed case among these 11 weeks. So we borrow the ideas from the social network analysis. We called the in-degree centrality. So in this map, we compute the differences between the May 20 and May 10. So you can see the pink and the light blue or dark blue, which means the morbidity reduction a lot for among this age group. Okay, so also you can find that it is correlated to the infection risk. And the other one we want to share with you is the extensive rapid testing. So in this figure, you can see in the Taipei City and New Taipei City, their temporal trend or positive rate of COVID-19 cases. So after May 31, you can see the overall positive rate is going down. And this is New Taipei City's data. So you can see the percentage of asymptomatic case in New Taipei cities was higher in June, and the younger population had a higher percentage of asymptomatic cases. Because the cases are going down, so you can see that also the we also reduce the silent transmission in the community. So you can see the overall epidemic is going down. And as we mentioned earlier, we were using the hidden period. We will define the hidden period later. So for those villages with longer hidden periods, larger than 3 days, the Department of Health will inform the district executive and the chief of village to encourage the residents to go to the rapid screening station. So these two figures are just one real example. So as you can find a red dash polygon, that is the village with patients, and the patients have having longer hidden period there. And we also identify where are the nearest rapid screening station to encourage the residents to go to there to get the screening. So this is one example for local health department to communicate with the district executive and to encourage their residents to take some screening. Okay. And how GIS can help to control the disease. This is detecting the emergence or repeated hotspot or identify the clusters in blocks. With the geocoding information, we can easily to identify the communities outbreaks or in a company or in a long-term care. So so using GIS can help you to understand where is something wrong. And also we're using telecommunication data and the confirmed case information to predict whether the village will have cases in the next 7 days. So you can see in the figure, in Taipei City and New Taipei City, we have 1,500 village there. So in this figure, you can see if we accounted for the highest 100 village there, the overall accuracy can reach to like 0.9. Okay, so overall, if we're using the telecommunication data and the previous 3 days information, we can have like nearly 65% accuracy to predict for the next week whether this village will have cases or not. Okay, so the next one is I want to share my perspective. So I think I already set up like the Sentinel physicians and the Sentinel community hospitals, the Sentinel surveillance systems there. So we want to highlight that if we can empower the local clinics and local hospitals to place some rules on disease detection or disease public health surveillance, that will be beneficial for future preparedness of epidemic or outbreaks. So this is my next slide. The first one is 2 public health intervention, including level 3 alert and extensive screening in the community, show the possible impacts on flattening the epic curve of COVID-19. GIS analysis and can help identify the possible cluster hotspot and mobilize resources to those high-risk areas. And telecommunication data can help predict the risk areas. So maybe later, the Professor Zhang will show more experience on that. And the next one, Sentinel clinics and community hospitals can play important roles on early detections, especially for younger population. Okay, thank you. This is my presentation.
Thank you very much, Professor Zhan, for the very nice presentation. I think we probably have time for one quick question, if there's any. So for those who are participating online, I believe you can see there is a Q&A session on your right or a chat box. So please feel free to type your response or questions during the presentation, and I will try to collect these questions and ask around either after the presentation or at the end of the session.
Can I ask a quick question? Sorry.
Okay, yes, please, Andre.
I wonder about, thank you for your presentation. I wonder about Sentinel data. So can you use, for example, rash and other indicators as indicators for COVID-19, not only obvious like bronchitis and so on? So can you develop a bit more difficult predictor?
Okay, thank you for Professor Andre's questions. Because of the time, so maybe we're using the syndrome group to collect. Like we already defined some COVID-19 related syndromes. Rash is rash already there because rash is not only specific for COVID-19 symptoms. So for like disturbance of smell and the taste, this is the very typical. Not say typical, but many people like in UK, they have this kind of symptoms. So we're using these symptoms as our indicators to collect the symptom side from the clinics and also the community hospitals. Yeah. So this is our syndrome groups here, only for COVID-19. But in addition to that, we also have other like 30 syndrome group layers. Not specific to COVID-19. Yeah.
Okay, thank you.
Okay. Yeah. Thank you. And with that, I'm going to move on to the second presentation. So the second speaker will be Professor Andrei Ahmanzanov, Anya-ke. So Professor Andrei is a assistant professor from the Epidemiology and Preventive Medicine of National Taiwan University. So he has been working on outbreak analysis for quite a number of years, and he has been actively involved in the past outbreak in May and June through the collaboration with the EIS, Epidemic Intelligence Information Center of Taiwan CDC, and some of the data from the daily press conference, for example, the effective reproduction number was actually calculated and estimated by Professor Andrei. So he's going to share with us the outbreak analysis using nowcasting to support policy making. So Andrei, please.
Professor Lin, thank you very much for your kind introduction. I was just happy to participate, and I did just a small work. So today, and as Professor Lin mentioned, mainly I was working about transmission dynamics of COVID-19 in Taiwan. And one of my tasks was actually to estimate the reproduction number in a real-time setting. So not when we know exactly that everything is happened and everything is finished, but when we try to estimate the reproduction number during the epidemic. So when, for example, some cases are not yet reported, and we try to predict how many cases are going to be reported, and also to adjust that some cases, for example, are asymptomatic at the time of testing. So we need somehow to back project and to predict the incidence. So today I'm going, because there is not much time, so I want to outline some particular outcomes of that analysis. But first of all, on the first slide, I want to show what was the epidemic situation in Taiwan. And I'm sure that you know it, but maybe some of the listeners actually are new to the situation. So in Taiwan, you can see that we observed quite many cases, but there was kind of detection of the big cluster in Wanhua City. And then we had the surge of cases, but after some time, because of interventions, that surge of cases was contained. And now we have less than 10 cases per week, I think, among local transmitted cases. And mainly there were level 2 and level 3. I will explain this a bit later. But level 3 was a bit similar to soft lockdown, when people were constrained in their movements, but not very constrained as for complete lockdown. And as in the previous presentation, you saw that the main hotspot was in Wanhua district, but there were also many cases in adjacent district like Banqiao, which is the most populated district of New Taipei City. And one of the main goals of my analysis, as I said, was to estimate the so-called effective reproduction number, RT. And why it's important? Because it allows to estimate the effectiveness of non-pharmaceutical interventions. So if we had this level 2, level 3, and strengthened level 3, then we would be interested in how effective they were, how effective they were in order to reduce the transmission of COVID-19. And in epidemiology, usually we work with a basic reproduction number, which describes the average number of secondary infections that is caused by a primary case in a fully susceptible population. But when there are some existing infections, or when, most importantly, when interventions are introduced. In that case, this reproduction number can be reduced and can vary in time. And that's why we are wondering about the effective reproduction number. So what, it would be the average number of secondary infection at given time in presence of all this interventional existing infection. And as you can see, because it varies in time, the desirable goal for any intervention would be to reduce the reproduction number below 1. And for Taiwan, as I said, the system of 4 levels was adopted. And for this outbreak, we had only level 2 and level 3. And mainly, and it was nicely summarized by my colleague Jenny Wu. And you can see that level 1 is very, very weak, but level 2 introduced some restrictions, but level 3 is actually to suspend all the gatherings and also to introduce the obligatory mask wearing. And what was important during our outbreak, that the strength at level 3, and I will show this later, it was important to characterized by the obligatory takeout policy for all food service. So it means that the people will not be able to go to the restaurant and would be obliged to take out the food. So they would not gather inside the restaurant. And level 4 was not introduced, but as you can see from here, it's mainly the strict lockdown. So the person would not be able to leave the house for non-essential reasons. But thankfully, it was not introduced in Taiwan this time. And mainly the level 3 was characterized by this. There was, as you all know, there was this QR codes and then restriction of pachinko places and other places, and also the fines if the people reject to wear the mask or to reject to follow the rules. And one of my tasks, and this is what I'm going to focus today, is that when we have this epidemiological curve, so when we can record the incidence, and if you want to estimate the reproduction number, then we need to take into account that there are a lot of delays between the actual infection of people when they experience symptoms and finally when they're confirmed by the authorities. So it means that if someone would get infected and the infection time is usually the time that is affected by intervention, then it's about 5 days before this person would experience some symptoms, including like coughing or difficulties in breathing. And then only after that, the person would probably try to seek for care and maybe would be allowed to take a PCR test, and only maybe after additionally 5 days or additionally even 1 or 2 weeks, this person would be actually confirmed by the authorities as a case of COVID-19. And you can see that if we simply take the epidemiological curve by the reporting date, then actually it would be quite imprecise with respect to the introduced interventions. Why? Because it would also take into account when the cluster was detected. So if the reproduction number would be very high, it means that maybe the authorities detected a new cluster. And then even if we take by symptoms onset, then it would be still backlogged by 5 days because of the incubation period to the actual infection. And our aim is in any analysis would be actually to estimate the reproduction number by the date of infection. So first of all, what I want to emphasize that if we estimate the reproduction rate, which actually is the estimate for the effectiveness of our interventions by reporting date, then you may see that the effective reproduction rate, the effective reproduction number can be very high when we just discover the new cluster of cases. For example, around May 13, the reproduction number reached actually the value of even the value of 8. It's simply because CDC and Control Center discovered this cluster in Manhua, and there was a surge of cases. So of course the reproduction number was very high. And it also accounts for this discovery of new cases. But actually this high reproduction number does not reflect the actual transmission dynamics of the virus. And later on, you may see that during August or September, this reproduction number also jumped. It's simply because a new cluster of Delta variant was discovered, so we had more cases, and then the reproduction number was higher. And currently, you know that the reproduction number for alpha variant of SARS-CoV-2 is around maybe 2, 3, 4. For Delta variant is about 5, 6. So you can see that the reproduction number around 8 is definitely the overestimate and does not reflect the reality. And that's why what we may wonder is about how to estimate the effective reproduction number, for example, by symptoms onset. In that case, it would be more accurate. And if we do this carefully, and first of all, if we do, as I said, for example, nowcasting, and then back projection of cases with unknown symptoms onset to likely symptom onset date, using the reporting delays, then we obtain a bit more realistic situation. And in that case, you can see that the reproduction number during that early stage in Wanhua district was around 3 and 4, which was predicted for the alpha variant. So it exactly reflects that it was unconstrained transmission of the virus in the district. And after that, when the interventions was introduced, the reproduction number dropped below 1. And currently, because we don't have many cases, you can see that it's oscillating, but it's can be a bit more, a bit above 1, a bit below 1. But we cannot say much because the confidence intervals are very wide. And now I hope I'm good with time, but actually there is a methodology that actually we can estimate by the date of infection. And in that case, if you do that, our reproduction number would be shifted. But now we can actually link this to the interventions. And this is what we did in our work. And if we do this, in that case, what we obtained is that the reproduction number linked to intervention was around 3 early in the outbreak, but then because of the interventions on level 3, you can see that it was brought below 1. And what is importantly, after strengthening the level 3, it was brought to be around 0.7, 0.6. So it was much lower than 1. And in that case, it's more precise to estimate this, and you can see that in that case, we can really estimate the policy making and estimate the effectiveness of the interventions. So for my presentation, what I want to give you is the take-home messages that the current outbreak was brought under control because of these interventions and compliance to the rules. And we were able to estimate precisely that reproduction number was brought below 1 after strengthening level 3. And I think that it was because of the stakeout policy and other restrictions. And estimation of the reproduction number can be more reliable if you use date of infection rather than confirmation date. And here I want to thank you for your attention, and first of all to thank Shenho Lab and Shenho Sensei, and also Taiwan CDC, who were very kind and very helpful. And I'm very happy. I was very happy to collaborate with them. Thank you very much. And if you have any questions, you can ask.
Okay, thank you very much, Andre. The time is just right, and I think we can take one quick questions if there is any. 如果是网络上收看的，你要用中文答问题也是可以。We take questions in Mandarin, in English. I can translate.
It would be funny.
So I think Andre's analysis during the outbreak was highlights the challenge, the real-time challenge when we look at the outbreak data and how we tried to reconstruct what was happening. And through this process, we also learned, I think, a lot about how in the future how to analyze these type of data. So if there's no question, we will move on and revisit mobility. Professor Zhang Xiaohan from Tsinghua University will be talking about combining mobility data to assess the risk of transmission. And Professor Zhang is currently a assistant professor in the Institute of Bioinformatics and Structural Biology in Tsinghua University. I have to say, although she's coming from the life science background, but her research is actually very public health oriented. So it's very good to have her with us, and she will be talking about this mobility data problem. So, Professor Zhang.
Thank you. Can you hear me?
Yes, very well.
Okay. Okay, thank you. Thank Professor Lin for his invitation, and it's my honor to present in this section. And I'll talk about how we combined mobility data to assess risk of transmission for COVID. And this is my first slide. So at the beginning of the outbreak or COVID pandemic last year, Caroline Baki, she was also my postdoc advisor. She built this COVID-19 mobility data network. And the purpose is to connect infectious disease epidemiologists with healthcare workers or policymakers. Because infectious disease epidemiologists, they have some experience of using mobility data. And while policymakers, they know mobility is really important, they have less experience. And so it's important to link them together. Since she also got a lot of requests from Department of Health. And nowadays, mobility data are more abundant than ever before. Few years ago, we still need to talk to mobile phone company and try hard to get the aggregated mobility data. But nowadays, like Google, Apple, or Facebook, they all provide open data for mobility, and this is a really good resource. But one thing to note that is except travel survey which we can ask people who got infected about their travel history, but for all the other data is for the general population. So it's not just for people who got infected. But this is still a really powerful data set, and this aggregated mobility data from one place to the other can help us understand or guess how disease might transmit from one location to the other. Yeah, and for international travel, we mainly use airport transportation data. And for other kinds of data, it's usually available and more useful for the domestic travel. Oh, and I highlight 3 data that currently have some open data available for everyone to use. And today I'll talk about 2 kinds of examples. The first one is I'll talk about how we inform the risk of importation and identify locations for surveillance. And Professor Zhang also talked about this at a smaller geographic scale in his talk. And the second part is we try to link mobility with disease transmission parameter and with the goal that when in the future, if we have this mobility data, whether we can estimate the risk of disease transmission. Because Professor Andre talked about how he estimated RT, but this requires case data. And but if we can use, let's say, if we can find the association between mobility and disease transmission, then we can, and mobility data are updated more frequently. So if we can use that to predict disease transmission risk, that would be good. Okay, so from the first one, and this is not done by us, this is just one simple example. So at the beginning of COVID-19 pandemic, a group of researchers, they compare the daily air travel volume between each country with Wuhan, China, and the number of cases detected in each country, and find this positive correlation. And this correlation can tell us that, for example, if a country for a given travel volume, the number of cases is lower than expected from this this line, then it is possible that there are some undetected imported cases in that country, and this can help inform like surveillance. And for the outbreak from May in Taiwan, we can do something similar. And so here I just want to talk about two kinds of transmission led by human travel from one location to the other. One kind of impact is from infectious travelers from Taipei, or at the beginning of the outbreak, we have more cases in Taipei and New Taipei City. And if those people from Taipei and they are infected and they travel to other cities, they can transmit the virus to susceptible people in other cities. And the other possibility is susceptible travelers from other cities, when they travel to Taipei, they can get infected in Taipei or New Taipei City and bring the disease back to their hometown. And so what we did is we used the case data and estimated disease parameters. Here, disease parameters include the transmission rate beta and also the proportion of infected in Taipei and New Taipei City. And then we, with this data, and then with mobility data or human movement data from Far Eastern Yuanchuan Dianxin, then we can estimate the potential number of importations from Taipei or New Taipei City to other cities or counties in Taiwan. Here, I didn't list all the cities because of the space limit, but here are the results, and you can see there are two colors. In means in means susceptible travelers, they travel to Taipei and get infected, and out means infectious travelers from Taipei and they travel in other cities and bring the disease there. And here you can see we estimate the number of importations and we draw a line in 1. And so when it's above 1, that means it is possible that there are some importations. It is all possible, but it's more likely that there are some importations and we should pay more attention to it. And Professor Lin's group also provide this results to the healthcare health department in all different cities. Okay, and then the second one is we would like to predict the risk of disease transmission using mobility data, and this is done by Novelate et al. And they published this paper in Nature Communications. They try to understand the relationship between mobility and RT, or effective reproductive number. And what they found is they found a significant correlation between them. So when the proportion of reduction in movement is higher, then RT is lower. But they do also find two different relationships. So the relationship got weakened after strict control measures were relaxed. And that is shown by the orange line here. And so we also want to look at this RT and mobility relationship in Taiwan. And this is what we had. And this RT was estimated from by Professor Andrew. So it's good that my talk is after his. So here the red line shows the RT estimate from May to the end of June. And the green line and blue line shows mobility data from Facebook Data for Good. And this is also open data. And the green line shows movement range. So you can think about that as like how much people move. And so when it's higher, that means higher mobility. And blue line is the probability of staying in the original location. So when this blue line or probability of staying is higher, that means mobility is lower. So we can kind of visually see some correlation between mobility and RT here. And so after this, we want to construct a statistical model, and with the goal that we want to use the fittest statistical model to predict RT, or I shouldn't say RT, predict the risk of disease transmission in the future. And so we all know that this R is composed of contact rate and transmissibility. So that transmissibility means given contact, what's the probability of transmission between a susceptible and infectious people. And the third one is the duration of infectiousness. So to understand this relationship, we use, in addition to using mobility, we also consider mass coverage, because when mass coverage is higher, then even given the same mobility, it will reduce it will reduce the effect of the same mobility on disease transmission or disease risk. And then the other one is vaccine coverage. Although when we train the model, at that time, vaccine coverage is very low. So we mainly use mass coverage and mobility data. But when we do the prediction, we do consider vaccine coverage. And for vaccine coverage, we use a 14-day delay because it takes some time for a vaccine to have some impact on immunity. Okay, and I didn't say, so for these data, so movement data and mass coverage, we got these parameters mainly from this grant. And sorry, I didn't translate this slide. So we had this grant led by actually this organization, public health organization, and it's led by Chen Baozhong laoshi. And we try to monitor how disease prevention behavior changed through time in the past year. And here are all the KPIs. So we got these parameters and the mobility data, and then try to fit the model. And here, oh, so sorry, I forgot to say that when I made the plot, I made the plot for 6 spatial sorry, 6度 and 6度. And because we don't have enough data to estimate RT for each county or city separately, so we do the analysis for these 2 different groups. And here, we just want to show you that we have this fitted model. And then the next, we will plot, we have this beta 0 and beta 1 estimated, and we can plug in the values from these studies and to do the prediction for risk of disease transmission. And we put our prediction in this dashboard for CDC or policymakers to read and use. Okay, and so this is the end of my talk. I don't know if I talk about this too fast or not. But anyway, I just want to sum by saying that consider mobility is really important, because mobility is how we transmit disease from one location to the other. And so understanding mobility can help us understand the spread of pathogens and help with disease control. And this is my final slide to thank Meng Qun in my group and Professor Lin's group, and especially Xiao Wu. She helped us a lot, and Professor Andrew and Da Zhou, he was also from Professor Lin's group, and also my collaborator, Facebook Data for Good and Yuanchuan Dianxin, and this 防疫新生活 grant we had. Thank you all.
Okay, thank you, Professor Xiaohan, for the nice presentation. I think we have about 2 minutes for discussion and quick questions. So maybe I can start by a quick one. So Xiaohan, you talk about the change in the relationship between mobility and RT before and after the sort of the lockdown, and I wonder whether you observed something like this in Taiwan, and whether you think it should be accounted for when we or when you use the sort of the pre-lockdown association to predict the transmission risk after the lockdown.
Yeah, I actually wanted to mention this, but I forgot. So this is a really good question. So because we trained this model by using the pre-relaxation relationship, so I would say that given the experiences in other countries that was analyzed in that Nature Communications research paper, I think our predictions would be like an overestimate, because for all the countries that paper analyzed, they all found a decreased relationship between RT and mobility. And the intuition behind this is that even given the same mobility, people have other, they change their behaviors in other ways. For example, they keep the distance, they wear masks. So this relationship between mobility and RT is decreased. And so, yeah, if maybe we can now revisit, because now we probably have some data after relaxation, we can reanalyze the I saw there's a comment from Dr. Andrew. But anyway, yeah, I haven't really looked at the recent data, but I would say I would expect a decrease in this correlation. And so our current estimation would be like overestimate. But I do think it's better to overestimate than underestimate the disease risk.
Yeah, I agree.
Let me see.
As long as we can anticipate the direction of
I want to see
bias.
Dr. Andrew's comments. I couldn't read the comments.
You mean the comment from Andre?
Yeah.
Maybe I can answer if I can ask. Sorry. Yeah. Thank you for your presentation. I was wondering this beta 0 in your logarithm for RT. Following this novel
the baseline
study, what does it mean? Maybe it would not be constant for early versus late, but maybe it would be also changed because of behavioral change and so on.
Yeah, I didn't. Yeah, this is a really good question. I believe that paper I cited, they've done this and they should have the answer. It's just I didn't pay that much attention to the beta 0, so I don't remember. But this is a really good question because it's like the baseline risk.
Yeah. All right. Given the time concern, I think we are going to move on. And I think in the last session, Dr. Zheng Haoyuan can also comment on the application of these prediction risk tools, because the original intention for this platform was to help risk assessment at the CDC level. So the next presenter will be Dr. Gu Juzhang from Imperial College London. So Dr. Gu is currently a research associate from the Department of Infectious Disease Epidemiology of Imperial College. And he and his colleagues have been working on the estimation of vaccination strategies under the threat of Delta variant. And importantly, they try to ask about the relative contribution of either maximizing the first dose of vaccination or instead trying to preserve some of the vaccines as a second dose for the high-risk population. And this is currently a very highly debated topic in Taiwan. And I would like Dr. Gu to talk about their research and findings.
Hi, can you hear me?
Yes, we can hear you.
Okay, thank you very much for introduction. Hi everyone, I'm Juzhang Gu. I'm currently working at Imperial College London as a health economics and infectious disease modeler. Today, I'm going to talk about vaccination strategy under the threat from the Delta variant. Firstly, let me introduce the meal of the day. I'll start here investigate the impact of different vaccination strategy on the people in Taiwan. We want to question what will be happening if there's an attack from the Delta variant when we, however, have limited vaccination capacity or vaccine availability, or we have imperfect vaccine compliance. During this, we start with the simulation modeling approach. I will lead you to the world of modeling with the 3 stages of infectious modeling. First one, collecting and synthesize data, then setting out a model and make it to and our target population alike. Let's say doing a couple of what if experiments in responding to our study question. In case that some of the audience here are not familiar with how modeling works in practice, I'll be focusing on the concept and the intuition without going too deep into the technical details. So for every beginning of a model, we need to bring a proper ingredient to our scope. That is something like structural assumption, parameters, especially for every model for decision support require parameter sourcing from empirical data. And for this project, we have 3 spaces to consider. First one is population, which is the Taiwanese population, pathogen, which is the COVID-19, and the Delta here means the Delta variant. And most importantly, vaccine for COVID. So about population, we have, of course, the demography with an age structure and background mortalities. And for simplicity, in this study, we group people into 7 age groups. And then with the data from national disease burden for Taiwan, we populated the distribution of 8 common risk health status. For example, like cardiovascular disease, diabetes, cancer, COPD, or obesity. Also making the population relevant to COVID for each combination of those health status and age groups. We estimate the risk of becoming severe cases and dying from COVID with a prior knowledge by literature reviews and the data from previous alpha outbreak between May and July. Then contact, no doubt, is an essential ingredient of infectious disease in epidemiology. We use a contact metric with household and non-household contact. And there are coefficients of them that can vary along with time, and which will be the function will be fitted to data and make it driving the model to follow the trend in the previous outbreak. Second, for the disease part, that is COVID-19, we need to know how the pathogen spreads, how disease progress, and how will help with if a person is diagnosed with COVID. Once a person is infected, there's a risk of disease activation. Following by incubation period about 5 days, the disease develops to either symptomatic, or severe cases. Then they will be detected and hospitalized. Also, along with this process, there's a risk of death. Keep in mind that no model structure is perfect. However, some of them are useful. And for example, here we have this model structure to match our research topic. Like we have people in hospital, like we can estimate the amount of the health capacity needed. Okay, until this stage, you already have all components available from previous outbreak. Therefore, we fitted the model to the time series of the cases from the last epidemic. We reduce the uncertainty of parameters and finally ensure the model was able to replicate the epidemic as the shared area behind the data. And also the age structure of cases and deaths have are matched to the data as well. The trend following the epidemic peak is due to the change in the intensity of non-household contact and by the effect of lockdown and also the other mobility reduction. The last component for the model is the Kovi vaccine. We consider the protectivity on infection becoming severe case and dying from the reserve values from literature reviews, and we combine them according to the current available vaccines. We have a synthetic population due for the previous outbreak, and we then vaccinate the synthetic population with a coverage as about 45% at least one dose, and 5% fully vaccinated with the record on early September as our baseline. Okay, and before conducting the experiments on the model, here is what we have now. So let's synthesize the population with age, comorbidity, and some vaccinated population. Then we can deliver the vaccine in the prioritization where we want to to test the risk of outbreak with the attack from the next wave. So let's move to the next stage. As an infectious disease model, the things that we do in our day-by-day life is asking what if. A simple one is like what if the risk of dying in 1 year if I drink a bottle of beer every day? Or what is the need for emergency room if today's temperature is over 35 degrees? For this study, the first what if we want to ask is question 1. What is the scale of the outbreak if there is an epidemic of Delta variant? To answer this, we need to have some Delta COVID, and we need to put them into our synthesized population. Then those let those pathogens spread and generate an outbreak, and you will possibly be in control. So here is a result of a simulation. We show the incident case with 50% and 95% credible interval. Uncontrolled outbreak and surprise outbreak are both possible with possibility of 13% and 87% respectively. The control run shows a scale of the epidemic will be about as twice as the previous outbreak. That is, even with the 45% vaccine coverage, the threat from Delta variant is still higher than the previous outbreak caused by Alpha variant. So then the second question we want to ask is, what's the risk of health system overloaded if we prioritize the coverage of first and second doses differently? So as a result of simulation, the result tells us that completing 2 doses of vaccination is more impactful than increasing the single dose coverage across all vaccination plans shown here, with different coverage like 60% for first dose, and among them 20% of the population have second dose. Across all vaccination lots of vaccination plan are the vaccine in the number of 80% population can at least provide 90% of protection against COVID infection, critical cases, and deaths. However, on the plot of people with COVID care along with time, we added a horizontal line of COVID debate. Unfortunately, with the vaccination at this scale, healthcare systems will be disrupted if we focus on the first doses. Then the next question, what if we encourage more older people to be vaccinated? Shall we start scaling out from young people, old people, or those with high risk comorbidities? So let's see. Along the three way of prioritization, mobility means people with the other high risk diseases. Of course, three prioritization, the older population are most important people to be vaccinated. Even we consider the transmission would be higher in young people. Lastly, we all know that there are some uncertainty around vaccine efficacy, and so we want to ask what will happen if we are on the unfortunate side. I mean, means the vaccine efficacy is actually very low. So a quick answer with our model is the need of healthcare capacity will be 2 or 3 times higher, and we may need more than 1,000 ICU beds for COVID patients. Then there are some take-home message. Firstly, if everyone in major and July outbreak happens again with the Delta variant attack, an outbreak of higher epidemic size and to the previous Alpha outbreak is expected. However, there's a chance that there will be an uncontrollable outbreak. Second, considering the impacts on infection, healthcare system, and mortality, letting some people getting fully vaccinated is more important than making everyone have their first dose. Third, age is always the key. To be noted, of course, every model requires some simplification. Models can only give us the insight into the topic we are focusing on. We capture the demographic features and comorbidities, where there are many components that we did not put into our scope. For example, the mobility pattern mentioned in the previous talk. And different people may have different vaccination compliance. Also, the geographical pattern like Great Taipei have higher risk of COVID. Also, vaccination is not merely a public health issue. That can be very meaningful to every aspect of our community, like social security, productivity, and economics, of course. And we must be very careful before taking any actions. Okay, and before the end of my presentation, I would like to give my thanks to the people who contributed to this study, And thanks to everyone here for listening.
All right. Thank you, Dr. Gu, for the nice presentation. I think we have time maybe for one question. Let me just read out. There's one question from the audience. Not sure if you can read it. I'll just read out. According to the case fatality estimated from references for the model, could we estimate how many patients of COVID-19 as a total back into the latest wave in Taiwan?
Okay, so in this study, we only take the relative risk of dying and becoming severe case from literature. However, the total number and the reference group will the risk of reference group will be estimated by making the overall risk of death matching the distribution of the previous wave. Yeah.
Okay, thank you. I think we're going to move on to our last talk for the session. So Dr. Zheng Haoyuan will be doing the closing presentation and from a policy perspective, hopefully. So Dr. Zheng is a medical officer from Centers of Disease Control in Taiwan, and he has done a lot of work with COVID-19, including many collaboration with the NTU College of Public Health. So he will be presenting about what policymakers need from epidemic analysis. So Dr. Zheng, please. Maybe you want to unmute.
Okay, yeah. Can you hear me now?
Yes.
Yes, okay. Hello, everybody. Thanks for the invitation. I'm honored to share my experience with from policy side and with students and those researchers. And I'm Dr. Haoyuan Chen, medical officer in Epidemic Intelligence Center in Taiwan CDC. So I think most presenters today has already showed their marvelous work for providing evidence for policy making. And I just want to share some concept to show what the policymaker may need from the epidemic analysis. I think the shortest answer is a recommendation of actions, especially in real world, which means it's executable, not in the ideal world. And maybe I can just conclude today's presentation with this slide, recommendation of actions. And however, in order to make a recommendation of actions, we need to link knowledge to action. So I think most researchers would provide a lot of knowledge or study findings. However, how the knowledge or the study finding link to action is the main concern for a policymaker. Sometimes the problem is from the research side because the research question not always meet the needs from of policymaker. Sometimes the problem is from the policymaker's side because the policymaker is not a professional for everything. So maybe they cannot just catch the idea from the professional side and turn the study finding into public health action. So I think what researchers and modelers should do would be find the right question and answer the right question. However, I think the responsibility is mutual. So what the policymakers should do is to ask the right questions. So if you can find the right questions and answer the right questions, you can easily turn your study findings into the policy implication. And for a policymaker, it's their own responsibility to ask a right question, not just come up with any novel ideas and ask the researchers and moderators to answer any fancy idea or fancy questions. So the communication and collaboration is pretty important. And so I'll provide some framework for policymakers and for the researchers to think about what we might need and what we do in outbreak analysis. This is a life cycle of epidemic or an outbreak. So we can see there are four phases for outbreak response. The first one is detection, and after we detect the outbreak, we will enter the early response stages. So we have to detect cases and start intervention. And in the intervention phase, we try to stop the outbreak. So the magnitude of the outbreak will go down quick, maybe shortly or maybe quickly. And after the end of the outbreak, we enter the post-intervention phase. And each phase, we have different missions. For example, in detection phase, what we need to do is risk assessment and keep the surveillance work so we can collect surveillance data and make rapid risk assessment for the probability of the continuing an epidemic. And in early response and the intervention phase, we need to detect the case as early as possible and initiate the intervention. And so we will have to plan the interventions and implement the interventions. And after the end of the outbreak, in the post-intervention phase, what we need to do is to organize what lesson learned in current or previous outbreak, and maybe we can formulate some policy according to the experience or the finding in the outbreak, and maybe we can conduct some retrospective academic research. All of them will provide a very important information of evidence for the future outbreak and the preparedness. So this is the framework for the outbreak data we might need in outbreak analysis. So we can group them into three groups: case data, outbreak background data, and intervention data. What Epidemic Intelligence Center do every day is just to establish a very reliable surveillance system. And so we can collect this kind of data, this outbreak data, in a daily routine and collect the structural data. So every time when there is an outbreak or an epidemic occurred, we can easily aggregate or analyze the structural data using our existing system. And sometimes, for example, maybe a new disease like COVID-19 occurred, and we might need to design some new study, or we need new source of the data. So that would be part of our outbreak response too. And this framework, I think, is also a very good reference for the policymaker or the researchers to realize or to know how to link policy decision to surveillance input, which is the data, the surveillance data, and what kinds of academic research we might need. I will take just one example. For example, if we need to make decision about the overall scale of the response, and what we might need is, you can just see the arrow. Yeah, if we would like to answer the question about the overall scale of response, and what kind of evidence we might need is about the transmissibility and the overall severity of the clinical case. So we can, if the transmissibility is high and the severity is also high, which means we need to scale up our response. immediately, so something like that. And in order to produce the evidence for the policy making for reference, and we can use the tool we can use includes maybe traditional statistical model or some transmit dynamics model, and an input data we might need will include 1, 2, 5, 6, which means confirmed case count and syndromic data from syndromic surveillance, and maybe serological data and some survey or hospital data, something like that. So this framework, when you every time as a researcher, when you being asked to answer some specific question from the policymaker, maybe you can just go back to this framework and see how can we answer the question. And as a policymakers, you can see if you would like to answer some questions and what kinds of tool you might need and what kinds of surveillance input means which means what kinds of data you might need. And if you don't have the data or you don't have a tool, you will know this is this will be a very difficult mission for policymaker or the researchers or the consultants. Yeah, so this framework can give you an idea about how to link the policy questions, policy decisions, and to the research questions and data. And this is another framework we try to adopt the idea of SEIR model to organize all the policies, control policies of COVID-19 in this framework. And I will go into every details, but all you need to know is every time when we are designing the policies, and actually we are trying to interfere the parameters between different stage. For example, how to prevent people from being susceptible to being infected, and the key parameter might include reproduction number or the probability of contacting with the suspect person, something like that. And this is the interest for study or for researchers. However, for policymakers, what their concern is the control measures, which means case isolation, contact quarantine, and social distancing, and just like something like this. And what policymaker have to know is what kinds of intervention we have to choose, and or how can we implement, or when we have limited resources, what kinds of intervention we might list it as the first priority. And because every policy will link to one policy will link to one specific parameter. So as researchers or modelers, and how to using your knowledge, your data, and your tools to answer the question, to estimate the parameters and reflecting into policy making will be another important mission so you can provide a very good reference for policymakers to decide what they would like to do and how they can allocate their resources. So for the outbreak analysis, so each stage will have different questions we would like to answer, or different missions. In detections, what we would like to do is risk assessment. So here I will provide some examples we really did in COVID-19 response. For example, because COVID-19 is a new disease outbreak, so and it happens outside Taiwan. So at the beginning, when we detect the case, the outbreak, what we would like to do is to perform a rapid risk assessment for importing COVID-19 outbreak disease, or the outbreak happened in Taiwan. So when we have very limited information, and the most we can do more like qualitative risk assessments, and we try to we can just collect as more data as possible for us to make the decision. So for example, last year when we are doing the when we were doing the rapid risk assessment, we also consider the travel volume between Wuhan and the other cities. So because the travel volume might be a good indicator, proxy indicator of the probability of importing or exporting the virus from Wuhan to other city, and you can find Taipei maybe was listed as the fourth high travel volume, air travel volume between Taiwan and Taipei. So which means which make us consider the risk of importing COVID-19 from Wuhan would be much higher than we expected. And we also have because just as I showed, it's more like a qualitative study. So we also collaborate with one company called Blue Dot, and they have some infectious disease model which can quantify the risk of case importation. So they can provide a more accurate estimate of the probability of importing COVID-19 cases within within 1 month. So this is just an idea that you to know. When we using the most updated air travel data, and the risk of importing COVID-19 cases from other countries to Taiwan might be from 11 to 100 cases, and so it might make the work as a reference for the policymaker to consider how high the risk of importing COVID-19 cases will be. And when the outbreak or when the epidemic occurred in Taiwan, which means we have local COVID-19 epidemic, and very important risk assessment and would be the real-time estimation of RT. And so we can evaluate if the epidemic will be going up or going down, or it can be kept stable. So thanks to the effort of Professor Ondri, so we can use our surveillance data to provide a real-time estimate of RTs and make a reference of the situation as the progress of the epidemic. So our policymaker can consider how to adjust their intervention and the risk level according to the evaluation of current epidemic. So we can find at the early stage, the RT will be very high. So we might need to take immediate action and level up the alert level in the right way, and maybe when the RT goes down, which means our intervention might be effective, and we can be more optimistic about our epidemic control. And for early response, very important mission would including how to okay. Okay, so in our early response, it will be very important to provide information about the transmissibility and evaluate the mortality and risk assessment. So it's very important to understand the underlying characteristic of the virus about the transmission pattern. So if the virus COVID-19 was more like SARS or more like seasonal influenza, would largely our response would largely depend on the different transmission patterns. So this is what we did in the very early stage. We tried to using the data from our contact tracing and to answer the question: when is the most when is the period has a high risk for transmitting COVID-19 cases? And so we try to use our case contact data to answer the questions. As you know, our finding is the risk, the transmission risk is highest, and at the first 5 days, within the 5 days after their first exposure. and attack rate would be much higher when the contact exposed to infected cases and during the very early phase in our study, which means within 5 days after the exposure, after the disease onset. Yeah. So the risk period is in the early phase of the disease. So what's the implication for policymaking? And our study showed early detection and isolation is key because the transmission risk is highest at early stage. And we also found some pre-symptomatic transmission. So pre-symptomatic transmission and early stage transmission will make the intervention very complicated and difficult. Maybe we need to do more generalized intervention like massive lab screening or a general use of face mask to stop the disease transmission. And to realize the risk period for transmitting the disease also can make it can improve the efficiency of our contact tracing and can have some contribution to decide the duration of isolation, so we can more accurately allocate the resources for quarantine and isolation. And our findings also been cited by the US CDC and in their ending isolation and precaution for people with COVID-19. So you can see when you can pick the right question and answer the question, and the policymaker will consider it will make great impact for the policymakers. It would really have influence on the protocol. Yeah. So as you see, let's say the isolation precaution can be discontinued 10 days after, and the key findings, including one large contact tracing study, and which is our study performed in Taiwan. So yeah, I'll skip up. Even for the contact tracing and the quarantine for the contact, we do need a lot of information from the study. For example, how long we have to quarantine the patient, and what's the close contact we have to quarantine. All these decisions all need very comprehensive research findings. So who are contact, who had a high risk, and what's the incubation period, what's the infectious periods, and all depends on researchers to provide solid evidence for us to make the decisions. And for interventions, and we can use the RT estimation to evaluate the effectiveness of our intervention. So thanks to Professor Andre, and he also provides some forecasts, and so we can know in the same condition what the trend will be for the current epidemic, and yeah. He also provides another model for evaluating the probability of new cases, and this is an example in one hospital outbreak. We also use these models in current local epidemic to evaluate if we will continue to have new cases after a period of intervention. So these all are all very useful information for the policymakers' reference. And post-intervention, we can evaluate the effectiveness of different interventions. So thanks to Professor Lin, provides another infectious disease model to evaluate the effectiveness of contact tracing and quarantine, and which shows even we are very proud of our contact tracing efforts, it's still not enough for the control of COVID-19. We need a combined approach, which means more general population-based intervention are still important, like face mask use and social distancing measures. So yeah, that's the end of my talk. As a researcher, I think the most important is to find the right question to answer. But for policymakers, and you need to know what kinds of questions you have to ask, and you can ask, and use the answer to make the right decision in the ideal world. Yeah. So recommendation vaccinations is most important. And the key to access would be the collaboration and communication between policymakers and the researcher or modelers. Yeah, thanks.
Okay, thank you, Dr. Zheng, for the very nice presentation. And I think we may have around 5 minutes for general Q&As. But let me first ask you, I think the idea about asking the right question and answer the right question is very useful. Do you think we are asking the right questions?
Yeah, it's difficult to answer this question, but I have already showed some good example, yeah, for the research for the use of the research finding or the study finding used in the policy making. For example, our contact tracing study do have great impact on the protocol of US CDC when they are making their protocol. And not all the decisions were made solely based on one study finding. For example, the finding of our researchers showed the risk period would be the first 5 days, but they decided to de-isolate the patients 10 days after because they need to consider other evidence from maybe biological evidence or other evidence from different settings, or because our study also have the limitation. So maybe the disease severity also a consideration when you are trying to de-isolate the patient. So the process of policy making would be very complicated. But if you can provide a very accurate and useful information, and they do have some impact on the policy making. Yeah.
Thank you. I think there's one question from the audience. Not sure if you can see it. I'll just read out the question. Now, in the past, local government always complied with the containment policy induced by CECC. Nowadays, CECC allows local governments implementing their local-oriented policy combating COVID-19, which resulted in huge differences across different cities or counties. How do you think about this local and central collaboration, contradiction, and compliance? I think this is probably more Dr. Zheng's question.
For me? Okay.
Yeah.
I think we cannot just set rules for everything. So the concept would be very important. For example, contact tracing is important for containing the disease, and contact tracing is not the only one effective measure. We still need to apply other MPIs to collaborate combined with contact tracing so we can stop the epidemic. However, we cannot control every single implementation details when the local governments try to doing their own contact tracing or their MPIs. I think this would be a very good there is a space or flexibility for every local government to perform their own contact tracing or MPIs according to their own local context. Yeah, just they also followed the concept or the central rule of CECC. For example, the risk period, the infectious, the risk period for the infection from the transmission would be 3 days. Now we say it's 3 days before symptom onset, and maybe 10 days or until the isolation, until the start of the isolation of the patient. And so they can just follow this solid rule, and how they performed contact tracing, how they trained their contact tracers. And for example, the new Taipei City may ask police officers to help their contact tracing work. because that's their own context, and some other counties will train their own contact tracer to do their contact tracing. I think the feasibility do exist for every local government. Just they can follow the most important rules, and which means maybe the incubation period, the risk period, or the central protocols made by CCC. Yeah, I think most of the local governments still have good compliance on our own protocol. Yeah.
Thank you. I think there were some questions towards the previous presentation. I think for Dr. Zhang. So let me just read out. There's one question about could you explain more about how to define the movement range? There was a question about there was some results around the movement range, and the other one is when estimating the association between mobility and the RT, is delay being considered? I think these two are for Dr. Zhang.
I'm not sure what that delay means, but when we so the RT can be like based on symptom onset, but for this association we used RT from Dr. Andrew, and that was for how to say RT by the time of infection. So it's not like I guess that means there is no delay between the two. It's like the date of by the date of infection, and that's the mobility on that date. One thing I didn't mention is for mobility data, we do see like the difference between weekdays and weekend. So when we did analysis, we use a weekly average, moving average, for identify the association between the two. And so this movement range means it's like the distance you travel to each time. And it's also weighted by the frequency that you travel. So if you only travel to like your neighborhood to do grocery shopping and you don't travel to another city or something like that, then the movement range will be small. And the resolution is about 800 meter times 800 meter. So if you only travel within 800 meter, then the data wouldn't be able to capture that.
Okay, thank you. I think maybe we can just have one last question, because as the chair, I want to make sure that we stay with the time. So the last question is again from the audience about what would be the role of socio-economic factors in the model and in policy making. So maybe I can ask Dr. Gu to talk about the role of socio-economic factors in the model, and Dr. Zheng can talk about socio-economic factors in policy making.
Okay, in terms of the socioeconomic factor, socioeconomic status, I personally, in my model analysis, I would like to do something like the stress test on the policy. If I do some policy on a population, if there any group of people or minority of people will be suffer more, or if these people will be benefit from the policy we consider for overall population. For example, if we do a vaccination that we sorting the population by their age, why ignore some people who are actually living in a very unprivileged and very poor setting, but they have higher risk of COVID or any aspect of their life, but not considered in this program. So it's very important to evaluate the equity and equality in terms of their baseline, and if they get if they are actually being benefited by public health interventions.
Okay, thank you. We know Dr. Ku is a health economist, so this would be something of interest. And I happen to think maybe we can also have Professor Zhan talk about socioeconomic from the perspective of GIS. But let me, maybe Dr. Zheng, you can first talk about the policy. There's a question about policy making. Yeah.
Yes, I think the equality of social economic status is really important for the implementation of the policy. And it's also important for the design of the intervention of the policy. For example, I think most of the policy we used for containing the COVID-19 would be more easily adopted or accepted by people has better health economic status. For example, they can afford to work from home. They can afford to stop work, or they can be in isolate for 14 days, and they can be afford to be quarantined with whole family, or and they have good family support for their kids, something like that. And actually, some interventions are not very friendly for the people with a little bit lower health socioeconomics or family support. I think that's the issue when we would like to continue to use this very high stress or very strict restrictions to contain the epidemic. This would be a very important issue we have to face in the long run. And if social and the analysis of socioeconomic status also can provide some issues about the risk factors for containing the disease or for the clinical severity, something like that. And however, we still have very few limited evidence on this kind of analysis. So if we keep collecting the data and doing this kind of analysis, it will provide us more information to prevent the disease in people with different, or prevent the poor outcomes for people with different socioeconomic status. Yeah.
Thank you. And so lastly, Professor Zhan, any insights from the GIS in terms of socioeconomic? Yeah.
Okay, thank you. I think I can talk this issue in two parts. For the overall part, like not directly related to GIS, like a financial support for in Taiwan, we have some financial support for quarantine people. So I think that issue is also very important to discuss in overall in the policy, because if we can we have this kind of subsidy to the quarantine people, they will have a more higher compliance to be quarantined. So I think these issues can be treated as a socioeconomic issue. And the other one in the most local scale or in the village scale, we are talking about like some vulnerable group or so in the community is very, very important, because like Dr. Zheng mentioned that will related to the severity or infection risk. Like in some districts, they have more older people there, or some homeless people there. There will be some risk issues there. And also the profile of the community. And remember, like in the United States, they created some indicator like this one, the vulnerable indicators, something like that. So they will be related to like the vaccination hesitate. So you can correlate in some community, they are a vulnerable group. They will be hesitate to get vaccination. So that's something like that will be directly related to the policy making. Okay, it's my opinion.
Yeah, I think because in the central government, we cannot just design one protocol or one policy to fit all situation happened in the local area. So actually, we are really happy to see researchers like Professor Zhang did. They have helped the local government to build their own risk assessment tool and to do more deep dive analysis about the risk and analysis and stratification for their own risk, transmission risk and disease risk, so they can design their own control policy on the basis of our central policy. I think this is a very good adoption. Yeah.
Thank you. Because of the time concern, I'm sorry for overrunning a little bit. I'm going to close the session, but I would like to thank the speakers again, all the 5 speakers, for the wonderful presentations and the very nice questions from the audience. And I hope you all enjoy the contents, and I enjoy a lot myself. So thank you once again, and hope you have a good day. Thank you. Bye-bye.
Thank you. Bye-bye.